simplified approach for primary hyperparathyroidism. So, to start with, a 60 years old lady with a history of recurrent kidney stones was admitted with abdominal pain and confusion. Her workup revealed normal ultrasonography for the abdomen, elevated calcium 11 milligrams per deciliter, low phosphate 0.9, and high alkaline phosphatase. Her rest of labs was normal with a mild increase in creatinine levels. By taking history of this patient, she was complaining of polyuria, polydipsia for the last week. So, how to approach this case? To start with hypercalcemia presentation, there is two types of symptoms related to hypercalcemia itself, like polyuria, polydipsia, anorexia, constipation, and peptic ulcer disease, muscle weakness, confusion, and cardiac involvement, like shortening of the QT interval, where there is also symptoms associated with increase of parathyroid hormone itself, like bone disease, nephrolithiasis, hypophosphatemia, and magnesemia, increased production of calcitriol, proximal renal tubular acidosis, and hyperuricemia and anemia. Regarding the causes of hyperparathyroidism, it may be parathyroid mediated, either a primary hyperparathyroidism, sporadic or inherited causes, or maybe due to familial hypocalciuric hypercalcemia, or even tertiary hyperparathyroidism and kidney failure, while non-parathyroid mediated causes include hypercalcemia due to malignancy, regardless of the cause, vitamin D intoxication, and granulomatous disease like sarcoidosis and lymphoma, or increased calcitriol injection, therapeutic hypercalcemia. It's noteworthy to say that 90% of cases of hypercalcemia either due to a primary hyperparathyroidism or malignancy. So the approach is once we see a high calcium, we should repeat the bone profile in a fasting sample combined with parathyroid hormone to confirm the diagnosis of primary hyperparathyroidism. If it is high, the PTH is high, this is the primary hyperparathyroidism. If it is in mid-upper normal or minimally elevated, we are either in front of primary hyperparathyroidism or familial hypocalciuric hypercalcemia. But if PTH is low, less than 90 picograms per milliliter, primary hyperparathyroidism is less likely, and we should evaluate for other causes, non-PTH mediated, like malignancy with measurement of PTH-related peptide. As a differential diagnosis of primary hyperparathyroidism, we can see that there is familial hypocalciuric hypercalcemia, primary hyperparathyroidism alone or with vitamin D deficiency. So, how we differentiate between these cases? We need obviously urinary calcium and vitamin D. In familial hypocalciuric hypercalcemia and vitamin D deficiency, usually the urine calcium is low, less than 100 in 24 hours, and also the vitamin D will be low in vitamin D deficiency. To complete our workup for primary hyperparathyroidism, we need a renal function test, urinary calcium exertion, parathyroid hormone, vitamin D. In some cases, we need celiac, like in normal calcimic hyperparathyroidism. Also, we should screen patients for complications with ultrasonography, QP, or CT, X-ray for bony lesions like brown tumors, and bone densitometry to see osteoporosis. ECG to see cardiac involvement, and for renal tubular acidosis and hypomagnesemia, we need VPG and magnesium. After confirming the diagnosis, we need to go to four localization methods. We have ultrasonography, we have system EV, planar or combined with CTs or SPECT CT. We have also for the CT scan, MRI, 3 Tesla or 1.5 Tesla, and most advanced techniques like PET scan using 18 fluorocholine. Of course, the most common and available are ultrasonography and system EB scan, which positive predictive value, which is about 90, above 90%, and 4D CT scan availability is specific for reoperative patient. The most sensitive and have high positive predictive value is PET CT, but it is for only some centers around the world because it need some special techniques and cyclotrons. So the positive predictive value and sensitivity is differ when the patient is first time or it is a reoperative, where the advantage in reoperative patients is for 4D CT and MRI, while the positive predictive value for system EB, ultrasound, SPECT CT, and PET scan is reduced in reoperative patients. To start with ultrasonography, which is the most commonly used and initial imaging modality, ultrasonography to define parathyroid adenoma need to be more than 1 centimeter. The parathyroid adenoma tissue will be like homogeneously hypoechoic. Sometimes it will be mistaken as suspicious thyroid nodules, especially if there is no separating tissue between the thyroid and parathyroid gland. Usually it is confined to the posterior aspect of the thyroid lobes, and its vascularity usually is peripheral. So as we said, there is thyroid capsule sometimes could be seen and separate the parathyroid from thyroid. Sometimes it's not seen like in these patients. There is a typical features for parathyroid adenoma like cystic changes in this, like in this picture, or calcifications, which are usually rare. Sometimes we can see these features with malignancy, but it is not pathognomic, so we cannot depend on it to raise the suspicions for malignancy. The next modality of imaging is system EB scan, which is also available, which is commonly used and fast to be done. Like we need to give the infusion and measure the patients after 2 hours. But the false negative rate is high in those patients. It reaches about 25% of cases, especially if there is calcium channel blockers use, if there is the thyroid disease like the multinodular goiter, and there is also misleading results if there is hyperplasia rather than the single adenoma, and also when there is multiple adenomas. The positive predictive value of system EB reaches 90%. It can be increased using the three-dimensional imaging SPECT or also the technique of subtraction of thyroid scan. We see here in the A image that there is a thyroid tissue. After excluding thyroid tissue, we see here the adenoma alone. So the evidence is increasing that those techniques are superior to maybe, and in many centers now SPECT is used as a standard of care with system EB scan to increase sensitivity. The 4D CT scan takes the advantage of rapid contrast uptake and wash out, which is characteristic for parathyroid adenomas, for precisely anatomical localization. Usually, image pre-contrast are taken, and then additional questions after injection, like after 30 seconds, 60 seconds, to see the parathyroid adenoma, like in this image here. We see how the parathyroid adenomas are evidence after contrast. The most disadvantage for this technique is very high exposure of radiation, which is more than 50-fold compared with system EB, but it is very beneficial in preoperative cases where the positive predictive value reaches 100%, especially if the initial system EB scan is negative. Of course, in this patient we see here, this is a right-sided adenoma, and there is a left-sided adenoma here in the white arrowheads. The positive predictive value also, when there is initial imaging, 90%, but it reach 100% in reoperative patient. The next modality of imaging is MRI, where the parathyroid adenoma on T1 imaging is low signal or intermediate signal in the T1 image, and it is high signal intensity in the T2 image, like in this patient, compared to the system EB here. Its usefulness also in preoperative patients to localize the abnormal parathyroid tissue with minimal radiation exposure. Its positive predictive value between 90% and 100%. With a high sensitivity, when there is dynamic sequences, sensitivity is between 90 and 93%. So the surgical treatment for those patients, there is candidates for surgery. Those candidates may have we have kidney involvement, like kidney stones and nephrocalcinosis. When there is serum calcium more than 1 milligram above the upper limit, when creatinine clearance less than 60, or there is kidney stones on CT or ultrasonography, when there is hypercalciuria more than 400 milligrams a day, when there is evidence of osteoporosis like fragility fractures or bone mineral density less than minus 2.5, and also younger patients are candidates like less than 50 years. So the surgical treatment, first of all, after confirming the primary hyperparathyroidism, we go for ultrasonography and system EB. If they are positive, we go to for surgery. If they are not, we can use another imaging techniques like a CT, 4D CT scan or MRI. And even some centers use venous sampling to localize the parathyroid adenomas. The surgical treatment may take advantage of measurement of parathyroid hormone intraoperatively, which will monitor the parathyroid hormone and help to visualize that we resected the correct adenomas using the parathyroid hormone measurement and the fall of parathyroid hormone more than 50%. The initial BTH harbors a cure rate of more than 97%. Every surgery has a complications. There is a general surgical complications like cervical hematoma, wound infection, permanent retrograde laryngeal nerve paralysis, operation failure, and hypocalcemia, severe or mild. The most important from our side as endocrinologist side effect is hungry bone syndrome, which is evidenced by low calcium, low phosphor, low magnesium. There is risk factors for hungry bone syndrome when there is increased adenoma size like more than 4 centimeters, when there is high alkaline phosphatase, low vitamin D, and severe osteoporosis, and also in the elderly patients and uremic patients. If our patient is not candidate for surgery or the primary indication for surgery is symptomatic like bony pains, severe hypercalcemia, osteoporosis, so we can use cinacalcet for severe hypercalcemia. We can use bisphosphonate or denosumab for osteoporosis and bony pains. If patients have severe hypercalcemia and osteoporosis together, we can use both cinacalcet and anti-resorptive agents. So thank you very much. This is the site for ectopic parathyroid adenomas.